Thank you so much, and it is a pleasure and a privilege both to be speaking at this platform, which is combined AIOS and OSWB, are hosts for the next AIOC 2021. So I'll be talking to you about cataract and cornea and eye banking, and these are the expert groups who did the cataract. This was very beautifully covered by Dr. Arup Chakravarti in a video where you have to have a declaration when the patient comes in the uh, pre-op area. And important thing is this: SICS in general is not aerosol generating procedure, but it is generally said that phaco should start with the anterior chamber filled with the OVD or the viscoelastic agent, and it is replaced by BSS, which is irrigated from the phaco tip. And so aerosolization, some degree would occur when the ultrasound is engaged. And BSS is the one which is the first one to be aerosolized when actually you are doing this procedure. So the pre-operative evaluation, I think I'm not going to go in details. The waiting hall guidelines remain the same. That means the patients have to be educated, they have to be seated appropriately. The registration counter, again, the appropriating distancing has to be done. And when the patient enters the chamber, then the hand sanitization is important. Slit lamp evaluation, again, it is best that only one person does it rather than multiple people doing it. And this is just to show how it will be done prior to cataract surgery. So you have to clean the equipment, and then you ask the patient, when you're doing the distance visual acuity, it is best to ask the patient to look at the last line or maybe the second last or third last. And when you're doing the near vision, it is best you hold the near vision chart rather than the patient himself or herself. And then a breath shield has to be there in the slit lamp. Again, sanitization is important. This was again very well highlighted in Dr. Ruth's video, that you have to dilate patients for cataract. Then either you can do it with the help of the swab stick, or the patient himself can actually evert the lead. Then indirect ophthalmoscopy can be done, but indentation should be avoided. This can also be done with the help of the 90D. And if you have a IOL master, then for calculation of the power, the instrument has to be sanitized. The ultrasonic probe that is there, every time you have to again clean it with isopropyl alcohol. And once the patient leaves again, then you have to clean it up. Subsequently, at all places, there may not be IOL master that may be present, and so you may have to do keratometry as well. And again, a breath shield is required when you do a keratometry. For intraocular pressure, avoid NCT, short tonometry or applanation tonometry can be done. This will be dealt by Dr. Manavdeep Singh. Lacrimal sac evaluation should not be done, and if required in the post-op period, the YAG capsulotomy can be done. It is important to completely discuss with the patient, and although it is said that it is at the discretion of the surgeon for COVID-19 testing, but at RP Center, we are not doing surgeries, even routine daycare surgeries for cataract, unless the SARS coronavirus tested is negative. We prefer to do daycare surgeries to be done by faculty, senior fellows, senior residents. Choose the quickest possible surgery. Try to avoid GA. Prefer topical anesthesia. Some people like to prefer peribulbar anesthesia also, because the patient is then not going to talk, because you don't want a talking patient when you're giving instructions on the table, because if he speaks, then the aerosol generation is going to be there. Of course, there's a separate area should be there for donning and doffing, and we have separate area for donning and doffing in the OPD as well as in the operation theater. So once the this is a quick video, but this video is can be made available as to how precisely it has to be done. Now, this is the way the surgeon dresses himself with the N95 filtering mask, disposable full face shield, sterile gloves, gowns, and shoe cover. And through the video, I'll just show you what is generally done. So both the patient and the attendant are masked in the recovery room. The hand sanitization is done. The operation theater attendant generally takes the patient inside. And we do have two tables in our OR, but we use only one now. We don't use the other one. And the patient is then made to lay down. And then this is a peribulbar anesthesia. In case you need to give it, it is best to give it on the table. So like I said, the advantage of this would be that the patient is not going to speak. Of course, you can do it under topical anesthesia as well. And this is at the discretion of the surgeon. In case of GA, The intubation is done by the anesthetist, taking all precautions, and the surgical team enters 20 minutes later after intubation has been done. Important thing is that betadine paint has to be done and allow it to be dry for at least 2 minutes. Then subsequently it is best if you have use the disposable drape, but you can use a linen drape as well. And again, the draping is very important because it has to be a completely drape which completely fits into the eye. And this is just cleaning, and then this is the drape, which is surgical drape, which has been placed. And following this, ensure that the pouch is open, and you don't want the fluids all over you or all over the patient himself, because you may be touching, this may touch your own clothes. And then the speculum is inserted in such a manner that everything, the lashes, etc., are underneath the drape. And after doing this, you ensure that the this thing is there, and copious amount of viscoelastic is available, because that is the most important thing for this surgery. Now I'll show you, these are the 4 suggestions courtesy of Bristol Eye Hospital. Again, we made a video, and this is a case of macular hole for which the cataract surgery is being done. So povidone iodine has to be there, suggestion number 1. So, and then after some time it has to be washed off completely. Then 2.2 millimeter entry is done. The smaller wound size you make, the less would be the aerosol reduction. Then viscoelastic copiously, and it can be put every minute. Try not to put a BSS or onto the cornea, or ringer lactate onto the cornea. Of course, capsulorhexis would be done as one does routinely, and then subsequently hydro procedure. Now, the most important step is this, that is when you put your phaco probe, we actually put the OVD or the viscoelastic agent right from the wound entry to, so as to seal it, and up to the end at 6 o'clock. So I think this step is very useful, and it helps to, and then this is irrigation aspiration, which we are doing for 6 seconds prior to doing phacoemulsification, because you want to do irrigation aspiration, and the whole aqueous needs to be replaced. The patient's own aqueous needs to be replaced by the BSS, which is flowing from the phaco probe. And then subsequently the nucleus, the epinuclear material is aspirated, and then the irrigation aspiration is done, and foldable intraocular lens is then implanted. Now, as far as the disposing the instruments is concerned, the sharps are discarded in a dedicated chamber, and all the instruments, you have to use only one set of instruments for one patient, and all the instruments have to be cleaned with the isopropyl alcohol. And when the patient moves out, all the linen and everything that is associated with this has to be then disposed of. Cleaning of the agents and disinfectants for ophthalmic instruments have already been described. The contact time is at least 10 minutes with isopropyl 70% alcohol. Then the housekeeping protocol is this, for all those who want to know. You have to, high risk areas have to be cleaned every 2 hourly, and it has to be done with 1% sodium hypochlorite, and this is the way to prepare it. Again, we use Corsolex Rapid, in which we actually put the instruments, and then following cleaning with this, like I showed you in the video, then you would again put them into the autoclave or the plasma, whatever. And this is then subsequently followed by appropriate measures with biomedical waste disposable. And post-operatively, you can ask the patient to follow up at day 1 or day 2, and subsequent consultation can then be with a teleconsultation. These are the guidelines which were published in Indian Journal of Ophthalmology. Now, coming to cornea and eye banking guidelines, there have been really not much, because what was allowed was a limited HCRP. Voluntary eye donation is more hazardous, and you don't have a COVID report, so that was something which was not allowed. And although again, COVID-19 was left at the discretion of the surgeon, but I know that most eye banks are actually getting COVID-19 done for the donors. And this is the algorithm which is generally followed for the deceased to take the donor corneas. So only when there's no epidemiological risk and the COVID-19 test is not negative, one can proceed with donation. And whenever there is any doubt, then one has to defer donation. Now, this is just to show, if you compare the last year's data the same period with this year's data, there's hardly been any donations. Look at almost 3,200 when we collected in April and May, and now it is not even 60 eyes which have been collected in April and May. Likewise, transplantation has also been very much decreased. And during the lockdown, of course, you can see that it is almost zero zero. These are the procedures which are urgent, semi-urgent, and elective procedures, and one can take a call on whether one wants to do these or not, depending on the emergency and the urgency. And now to our armamentarium, where we used to train the technicians to retrieve how to retrieve the eyeballs. We have now also started training the technicians on how to do a PPE, how to wear a PPE, and how to get out of it, and then how to collect the eyes. So these are the iBanking and Cornea consensus guidelines by a combined AIOS, Cornea Society of India, iBank Association of India, and the ISCRIS. And to conclude, COVID-19 has led to unprecedented times, and I think we all have to change the way we are doing our ophthalmic surgeries, be it anterior segment, posterior segment, or any surgery. So I would like to thank the Governing Council for all the guidelines. We had late night meetings to finalize these, and each and every member contributed to these. All the managing committee members, again, where we had a meeting with them, and the back office team, Mr. Kripal Rana, Rakhi Nekhawat, who were helpful in creating these guidelines. And of course, Dr. Mahipal Sachdev, who was instrumental in carrying this forward. Thank you so much for your kind attention.